you at the end, but would appreciate it if everybody could please complete that. And as I've already mentioned, don't forget you can use the chat function to ask any questions throughout the session. Next slide, please, Ashma. So at the last session on the 8th of March, we had some feedback, and it was a gentle reminder for us all not to use jargon and acronyms, because not everybody understands these unless they're specifically explained at the beginning what they mean. We have produced some a jargon buster for today's session, which I hope everybody will find useful. A regular agenda item on updates and engagement as the ICS and white paper rollout would be good, and that's something that we'll consider at a later or at a future meeting. Update from a surgery GP perspective of changes, e.g. changes to access for appointments, prescriptions, etc. And we need to consider how we share messages from this forum to a wider audience and demographic. The other feedback was it would be useful to know how the NHS sees itself coming out of lockdown. How will appointments and procedures improve? When is hospital likely to be allowed again, and what additional safety measures will be put in place to allow these to happen? Can we have the next slide, please, Ashma? So I would just like to give everybody an update on the engagement team. We've had two new members of staff join the team. We've got Jake. Jake, I don't know whether you want to say hello.
Hi, everybody. I'm Jake. I used to work for the Royal College of Nursing, and my background is also with the civil service as well. So it's really nice to be part of the team. Good to meet you all.
And Jake will work closely with you all moving forward. Jake's going to be covering the Gateshead area. And the next new member of the team's Ashma. Ashma, do you want to say hello?
Hi, everybody. I've come over from the Integrated COVID Hub, and my strengths really and my experience lie in community development work. So I look forward to working with you all.
Oh, yes. So both Jake and Ashma started with the team on the 1st of April. And they're in a process of getting a handover from Lindsay. Lindsay's actually on the call today, but as you all know, Lindsay has moved on to another role within the CCG. And I'd just like to take this opportunity to thank Lindsay, as I'm sure we all would, for her valuable input that she's provided to us all over these, the previous years. So thank you, Lindsay.
Thanks,
Kirsty. Oh, you're welcome. So, in March, the Gateshead long-term condition patient group met, and they will be supporting a piece of research focused on engaging with GP practices digitally with their long-term conditions annual review. And I think that's about it for the engagement update. Today we've got Caroline, who's come to talk to us about primary care networks. So I'd just like to introduce Caroline. Hello, Caroline.
Hi, everybody. Nice to see you.
So, Caroline, I'll hand the presentation over to you. But if you let Ashma know, she'll turn the slides when you're ready. Thank you.
Yeah. If you could turn the next slide, please. Okay. I think really primary care networks, I guess, is something as a term that's been around for the last couple of years, and I guess this is really, apologies to anybody who knows what a primary care network is, but we just thought it would be worth kind of giving everybody a recap around what this is all about. Because primary care networks were established in 2019, and across Newcastle and Gateshead we have 12 primary care networks. So I'll go through some of the detail of that in a little bit. But I guess they were just kind of getting up and running and started and thinking about what their priorities were and how they would get better at working together as a group of general practices, I guess. And then COVID happened. So I guess there's this sort of primary care network development was somewhat stilted, that probably is the best way to describe it. However, saying that, there are still some benefits that have been realised as a result of COVID, which we'll run through generally. So just on that first slide there, just gives you a little bit of information. The focus of primary care networks is to have general practice working more coordinated and across the health and care system, working typically, it says there, between 30 to 50,000 plus patients per primary care network. The basis of that number is on the basis of it was perceived or seen to be large enough to get economies of scale, but small enough still to be personal, and for it still to kind of impact on an individual's direct care in that sense, in terms of improving the outcomes. Each primary care network has to have a clinical director, which in fact, all of the cases across Newcastle Gateshead, that's one of the GPs from one of the practices within each of the networks, and they have a management lead. And then the CCG has also aligned a member of staff to support that primary care network in terms of its development and ongoing work. My role, I guess, would be within the CCG has been around trying to coordinate the work of the CCG in supporting primary care networks, because it was felt that it kind of touched on nearly every part of the CCG in terms of clearly engagement and involvement, medicines management, mental health. It looked at estates, it looks at workforce, it looks at contracting and commissioning. So it was kind of within the CCG, we really wanted to try and make sure that everybody had sight of the development. So as a project management office, we were asked to kind of have that level of oversight and support people to kind of get primary care networks up and running, really. If we could move to the next slide, please. So again, just very, very briefly, clearly, there's lots of things going on in terms of primary care networks, and the aims and objectives are way broader than probably what's just written on this slide, but just that overview, that is about the better personalised care, closer to people's homes, improving access, and again, we probably know, just picking up from the summary of the feedback from the last session, clearly access is a particular issue that's been explored and will continue to be explored, I'm sure, over the coming months, and now how things are accessed differently, how general practice is accessed differently as a result of COVID. It's a great opportunity, I think, for primary care networks. And I really do believe that primary care networks are a huge, huge opportunity, that we're just, even though now officially 2 years in, starting of year 3 for primary care networks, it is still really at the start of that journey in terms of kind of achieving those aims in full for the primary care networks. So go to the next slide, please. So this slide, again, just summarises the 7 primary care networks. I'm not going to run through a lot of detail in here now. I'm assuming these sort of slides will be shared with members of the forum, so you can take them and look at them kind of in your own time in that respect. But it just shows you which practices are part of which networks and their population sizes. And you can see across Newcastle, we have the sort of smallest network of West End Family Health, which has just under the 30,000 kind of threshold, through to Newcastle East, which is a big network covering 80,652 patients. But every patient across Newcastle and Gateshead is covered by primary care network services. The next slide, please. So again, just information, I'm just going to flash up these next few slides relatively quickly to say who the clinical director is, who the management lead is, and I've just noticed on here with the acronyms, NGPS is Newcastle GP Services, which is the Newcastle Federation of General Practice that is there, and they support 6 of 7 PCNs, primary care networks in Newcastle. So you'll see for a lot of them, NGPS is the management lead within there. So if we move to the next slide. And then the next one. So that covers the 7 primary care networks in Newcastle. The next slide gives you that same information with regards to the Gateshead practices And again, you can see sort of a range in size with Gateshead East being again just under that 30,000 threshold, through to Central South, which is 66,000 almost in terms of the population that are covered. There's been some changes in the network in Gateshead for this year, starting in April. Second Street as a practice moved from Gateshead Central South into Berkeley, Oxford Terrace and Roland Road as a network. And it was that, part of the reasons for that was a much better fit in terms of location of patients and therefore being able to support patients better to access services. We move to the next slides. So again, just runs through to tell you who the clinical directors are. And I've been informed Gateshead Outer West, Samina is stepping down and there's a handover, and this is how hot off the press this is. I don't know who the new clinical director name is in terms, or I didn't have it at the time of doing the slides. So maybe before we circulate these, I might get a chance to update that so that at least you get the information that is the most up to date. Next slide, please. So again, just covers off a who's who for you to work through in your own time. So next slide, please. So primary care networks, the whole premise is that the general practices work together to improve services for patients, but also they have some contractual requirements, and the contractual requirements can get quite complicated on the basis of it's each individual practice that signs the primary care network direct enhanced service, which is known as the DES. They sign it as an individual practice, but that contract essentially says they're going to work as a group, as a network. So there's some potential contradictory bits there, or sometimes I think it just feels like it's quite hard to get your head round what's actually happening or how that all works. But we're all working through it, and I guess in some ways we do work through it together. So primary care networks, there's three elements to that direct enhanced service that networks have to focus on, and that's looking at structured medication reviews. And again, there's a load of detail that sits behind these bullet points that in some ways I know some, and in others I profess to know very little. The structured medication reviews, there are, and you'll see the second point there, additional role reimbursement scheme. Every network has to have a clinical pharmacist through this scheme, which is an additional member of staff, which would support the delivery and development of that structured medication review contractual requirement. The enhanced health and care homes, again, is work that across Newcastle and Gateshead, and I've noticed some names on there. People will know me from previous role around the Care Home Vanguard programme. It's work that in sort of care homes that across Newcastle and Gateshead has been going on for a long time. So people are well versed and well cited and are really supportive of that approach. So this builds on that. In essence, the contractual requirements for primary care networks has built on that Vanguard programme of work around enhanced health and care homes. And then again, supporting early diagnosis of cancer, lots of work already going on, but this just in some ways may formalise it, and has been working, people have been working on these things for the last, certainly started it in year one of primary care networks, which was 1920, and then obviously COVID has predominantly taken over in kind of year two of 2020-21. But these elements are starting again in 21-22. So primary care networks have had sight of these requirements for a long time. So it shouldn't be any surprise that these things are starting to kind of roll out. So additional role reimbursement. Obviously, I've just mentioned that there in terms of having a clinical director. A clinical pharmacist. The other role that was contractually determined that primary care networks had to have was at least one social prescribing link worker. So again, different approaches have been taken, but every primary care network has both of these roles in place. In the main, working with for clinical pharmacists with CBC in Gateshead and also Newcastle hospitals in Newcastle. And then in social prescribers, there's a mix of approach in Newcastle using the voluntary sector, and also I think nearly all of the social prescribers in Gateshead are working through Edberg's House, which have that sort of strong established social prescribing background, I guess, locally, which is really, really good, because again, that goes back to, for me, the concept and the idea of a primary care network in terms of actually supporting the local community and having people in your local community that can kind of support and help and carry out some of the requirements of the contractual DES, the direct enhanced service. And then obviously there's an investment and impact fund, which is a financial incentive that covers payments that are based on a primary care network's performance. And again, that's nothing new to general practice in that sense, in terms of the range of schemes and areas that they can kind of get involved in and work together on. I guess it's in some ways primary care networks have been developed, and in some ways we've seen a shift in how funding flows into general practice because of the development of networks. The funding will now generally come through the network, and then it's therefore how the network then work together to enhance the services. And that's where, going back to where I kind of started, I guess, in some ways, because the being big enough to have the economies of scale, but small enough still to be personal in that 30 to 50,000 population. So hopefully we should start to see some potential changes for the better, hopefully, in terms of how patients are able to access those services moving forward. I'm going to take a breather and ask, does anybody have any specific questions or at this point before I move on to the next kind of stage? So I've got some comments here, just as a particular reason for Newcastle East being so high. No, I said, oh, excuse me, get my teeth in. No, not necessarily. I think it's around the relationships that exist among the general practice, the GPs in that area, that they all agreed. I do remember thinking it, when way back in 2019, there was a conversation of, we're a practice of 8, do we go into 2 4s? And that was a potential option at one point, but actually they then decided they would be better in terms of being a bigger network. And in some ways there's some advantages to being bigger network in terms of the way the payments are flowed. So for example, the clinical director, because it's such a big network, actually gets, and whether this is right or wrong, don't shoot the messenger in that sense, because in some ways you could say it's not necessarily the right thing. They get more money for their clinical director because they're a bigger network, in the sense of it goes on the size of their population, so they have more resources to invest in that area. So then we've got David, are you confident that social care providers, patients, carers will have a real voice in the primary care network and larger integrated care systems within? Well, now, wow, what a question. Good question. I'm not sure I've got the answers. I would have said I am confident that every effort will be made to make sure that there is a real voice in primary care networks. And I think in some instances, for me, this is part of that conversation and real voice, hopefully, that we'll be able to develop. In terms of larger integrated care systems, I think there's a real challenge there in terms of getting primary care's voice in there. We're not quite sure exactly where primary care is going to sit in that sense moving forward, from the change from CCGs and that new structure that's going to be there. But certainly from the work that I'm involved in, certainly from others that I know are involved with primary care, that's very much at the front of our minds when we move forward. And then Violet, how much are GPs given in regard to the investment and impact fund? again, I think that the investment and impact fund, there's an amount allocated out to each area, and then that the sort of criteria has to be met, I guess. And if the criteria is met, then that funding is fully made available. I think locally as well, we do a lot of work and support in terms of how people will take that forward. I guess there's a lot of detail to kind of how to, it's difficult to say how much our GP's given in regard to the investment impact fund. I think the general bit is we will use it to the best effect that we possibly can and get the best benefit out of it, I guess, in that sense. So we try and use it all that we can. Lindsay, do you sense that PCNs are up for engaging with the public? I think they absolutely are up for engaging with the public. I think they have just been stymied by the impact of COVID and managing that at this point. But certainly when I've mentioned to the clinical directors that I was coming here today to talk, for example, most of them have said, oh, brilliant, that's a really good start. Let's see where we can take it from there. And I think certainly as we go through today's presentation and into the conversations that we have afterwards, I know I've already sort of lined up within Newcastle and Gateshead to take the feedback back directly to clinical directors to say, right, so okay, so what is it we're going to do next? So certainly very much a starting point for that. Will the PCNs use the already existing patient participant to assist future work? I think, well, I would hope so, Anne, in that sense, in terms of, I think, again, that's part of the conversation that we're going to have, hopefully, today and this afternoon. And then perhaps now is the time to propose and make a case for PPGs in the PCNs and to plan them to new ICS. Again, hopeful, Judy, that'll come out of maybe some of the suggestions that we get today in terms of how we take that forward. So yes, let's fingers crossed that'll all work nicely. And it sounds like from those comments that people are quite up for looking at how we can do this and make that engagement better. So that's really, really good. So if we move on to the next slide, please. Okay, so again, just I guess a focus, which I'm sure is probably top of everybody's head and mind in that sense in terms of health inequalities. It's on the PCN agenda. Primary care networks have had to identify a health inequalities champion to kind of look at what it is that they do and how they will take that forward. And that ties in, again, going to give you a little bit of information around the sort of health system and the CCG. If we move to the next slide, just in terms of what we're required to do and what the system is obviously looking at there. So again, there's 8 urgent actions to address inequalities, which are ongoing. 21-22 priorities in operational planning that outlines those health areas of health inequality that we must do. And again, you know, the brief update that in terms of the feedback from the last session that I noticed in that Kirsty was talking about this morning, you know, this inclusivity, the restoration of NHS services, I think some of the digital work, they're all there. It's all stuff that we know. And I guess it's just having that big focus on those areas that COVID has kind of highlighted that actually, yes, we do need to do this much more perhaps openly and explicitly than we have been doing previously. Because again, I don't think for one second that anybody has deliberately been excluded in any way, shape or form in terms of the services that are available, but perhaps we just haven't had it at the forefront of our mind in that sense in terms of taking that work forward. So given all of those sort of areas that we had to work on, while we move to the next slide, one of the things I think that probably primary care networks had not been in a position to do because of COVID was to have this real focus on it. So we are working across Newcastle and Gateshead to get some information and support available to give to the primary care networks. And I think it's probably going to happen really quickly now because we are starting to move back into a more normal state, I guess, in that sense, in terms of managing the pandemic. But however, the pandemic has, as that first point there says, given that opportunity for building of relationships between primary and secondary care, has drastically improved and developed, I would have said, as a result of the pandemic. enabling much better, closer working relationships. We're looking at an outcomes framework for each system, one for Newcastle and one for Gateshead, that's been developed across the health and care system, in that sense, in terms of taking the work forward. And again, we're now looking at how do we drill that down to a primary care network level, in terms of the sort of data and information, to make sure that primary care networks fully understand their local communities and local populations. I would say, and I would say this to primary care networks as well if they were here. I think general practice, I think GPs really know their patients, but they don't necessarily always really know their local communities, because we know that not everybody will engage in their general practice. So not all of the patients are known to every, to all of the GPs in that sense. So we know generally that, there's areas of deprivation, there's areas of Black and ethnic minority, populations, etc., which have different and identified, well-known needs that are prevalent in certain areas. But I think it's that bit around understanding the level of, employment, the housing status, the number of young people engaged in education, etc. Those other things that are kind of the wider social determinants of health and care, and all the things that impact on somebody's physical health as well as mental health, that we really need to kind of get primary care networks a little bit more focused on, probably, moving forward. I've just got a comment here. I'm just looking at Violet's public health and health education is vital in promoting good health in the community. Brilliant. Yeah, definitely. So if we just move to the next slide. So again, for primary care networks, what's next, I guess, in that sense? They are continuing with the COVID vaccination programme. And I would say, again, if people haven't seen or experienced that in Newcastle and Gateshead, hopefully you will do very soon, because I think it's been a massive, massive effort and a great programme that's been implemented. I mean, having been involved and seen, and I've volunteered a couple of days to kind of help out there. It's been an absolutely amazing feat to get so many people vaccinated so quickly, and that's going to continue, because the primary care networks have generally agreed that cohorts 10 to 12, which is the 50 and under population, is going to continue within within public health. Not public health, within primary care over the next few, well, quite a number of months, I guess. So is everybody having their first vaccination, every adult having been offered their first vaccination by the end of July. So still, a lot of work to go. However, having said that, and that's, a big focus for the primary care networks, they are also now continuing with the development of their primary care networks. So again, for me, this is the start of some of that, and the conversation that we're going to have here today, this afternoon, will be to help the primary care networks to pick up and continue with their development. And I've put their engagement with a question mark, because I think probably most primary care networks would say that it's perhaps an area that they haven't necessarily done a lot about so far. Certainly in the last 12 months because of COVID, but however, it is an area that they're all very keen to kind of get much more actively engaged and involved in themselves. So again, really good starting point to kind of take this forward. So just before we then move on, I'm just going to look at these last couple of comments that we've got. We talk a lot about community defining in many areas. Yeah, and I think, again, that's lots of learning and input for me, for people from this group, to kind of help inform primary care networks in their approach. In terms of, we talk, I think, again, we go right down to kind of almost micro communities, and I'm using the term community there very loosely in that sense, in terms of much, much smaller groups of people who live in an area, and whether they identify as a group or as a community, or actually they're just in the same geographic area. I think there's many differences across there, and I think the challenge is, again, how do we deal with such a wide range of needs for people? So I've then got, how do out of our GP services fit into what you have just outlined in terms of primary care networks? So the primary care networks and GP out of hours, and I'm sure that somebody, I think I've seen Dominic on pop up here. You might put me right on this. Out of hours GP services are a separately contracted service, but obviously they will have links into primary care networks and will work across all of the practices in Newcastle and all of the practices in Gateshead, because there's two different services that cover Newcastle and Gateshead. So they're not specifically linked from a contractual perspective, but we do know that a lot of the GPs that work both out of hours services do also work in hours and in terms of the primary care networks that are there as well. So then we've got Fozia, yeah, brilliant information there coming out from the census. I think is definitely information that we will need to be working and using, definitely. It absolutely is. Social prescribing is still a big part of primary care networks, and I don't know whether you were right here at the start, but certainly every primary care network has at least one. Most now have more than one social prescribing linked worker employed through the additional role reimbursement scheme. So it is very much a big part of the programme moving forward. So what we want to do now, if we can move to the next slide. Just before I'm going to hand back to Kirsty in a minute, just to kind of say these are some of the questions I think that we would like to kind of have the conversation with you about this afternoon. And I think there's that bit there in terms of, and maybe some of this will sort of focus on some of the comments that we've already had, is how can you individually help? What is it you think you can do and help bring us together in terms of increasing the sort of involvement and engagement of primary care networks? The patient participation groups, again, how can they support primary care networks? We know that individual practices within their kind of general core general practice contract, they have to have a patient participation group, and that's still a contractual requirement. That's not going to go away. There's nothing in the primary care network direct enhanced service that says they have to have such a group. I think it's suggesting that actually, you know, engagement is clearly key, but because that's part of the core general practice, it's not a duplicated contractual requirement. So I guess that's, you know, some of the challenges of how do we get primary care networks to get perhaps more involved, or is how do we sort of say, do we have a primary care network patient participation group as well as individual practices, and what's the difference, I guess, in some of those, and it would be really good to kind of chuck some ideas around, I guess, in the conversation that we have around that. If you're representing an organisation, how could your organisation support primary care networks, particularly around the engagement and involvement agenda? That going back, primary care network, PPG, would it be effective? What's the benefits, pros and cons of all of that? I think we really want to kind of do, and how would we make it happen? What would it look like? Do we need to develop a plan to support the wider engagement? And maybe it's a plan then that's trialled within one or two primary care networks who are keen. Although I do know that actually, you know, there's a number of primary care networks that are really keen to get a lot more active in this area. So it's a real opportunity for members of the forum to kind of influence and shape how that can happen. And then I'm just going to, there's one last comment just come in there. So virtual only even before COVID. How do we see PPGs do not physical meetings or virtual only? Very good question again, and I think that's one to kind of be debated about, I guess, a little bit more in the conversations that we're just about to have. So that's the end of my presentation. Kirsty, do you want to come back in?
Yeah, Caroline, there's one more question that's just popped in the chat box.
Okay, why not define? Okay, yeah, it's quite a divide, but areas that obviously there's 7 areas in Newcastle and 5 in Gateshead, certainly something we can contact or consider and think about how we would maybe practically do that. I guess that would be the challenge in how we do it, and is there people there for each of the areas? I'll leave that to the group, I guess, because I think in that sense, from a CCG point of view, we're quite happy to be open, and obviously we'll need to work with the members of the group here and others, and also the sort of primary care networks themselves.
That's lovely. Thank you, Caroline. Does anybody else have any more questions for Caroline? They can either raise the hand or put the questions in the chat box.
Hopefully there'll be more questions come out of the conversations and discussion.
I mean, the second part of the meeting, what we're going to be doing, I mean, we're a little ahead of time. So what I propose that we do is we'll have our break earlier. And what we'll do is we'll resume around about 5 to 3. So what we're going to be doing in the second part of the meeting is we're going to be using breakout sessions today. And during the break, we're going to split the group into smaller groups of participants so we can consider those questions that's shown on the screen now, plus any other questions that's not being covered. And what you'll do is you'll have the opportunity to ask any further questions, and what we'll do is we will collate all that feedback and we will share that with Caroline at the end. At each breakout session there will be a facilitator, and we'll just gather together and then we'll provide some feedback. Some devices are not supported for breakout rooms, but what we're going to do through the break is we're going to just split the group into 2 groups, just with even numbers, but there'll be smaller groups. And then after 30 minutes, what we'll do is we'll come back and we'll join as one group. And then what we'll do is the facilitators will provide feedback on what was discussed and any questions raised, and we'll feed back at the end of that. So it's 20 to 2 now, sorry, 20 to 3 even. So what I propose we do now is we have our break. We'll take our break. Sorry, that's my dog. We'll take our break early. Please, can you please put your microphone on mute and also knock your camera off, and we'll see everybody at 5 to 3. Thank you. Is that okay with everybody?
Yes, thanks.
Brilliant. And thanks very much, Caroline, for your presentation. It was really good. Thank you.
You're welcome. Thanks.
Hi, are we still waiting for a facilitator, do we know? I've just joined and it doesn't really look like we've got one, does it?
No.
Right, bear with me a second, I'll see.
Sorry, that'll be me. I didn't.
Oh, it's all right, Dan.
Apologies.
It's fine.
I was fully expecting to be introduced and then be popped in the group. Sorry.
It's all right, it's no problem.
That was my mistake.
Don't worry.
So yes, I'm going to be the facilitator, but hopefully that should really just be me asking some questions and listening to yourselves speak. So what I'll do is, because I know the questions were posed within the main meeting, which we don't have access to now on that PowerPoint. So what I'll do is I'll just pop them in the chat, so then we can see exactly what the questions were, and then we kind of work through them. Does that sound okay to everybody?
Mm-hmm.
Great. Yep. Give you 2 seconds. I shall do that.
I've done it, Dan.
Oh, you've done it. Great. So as you can see in the chat, quite a big font. We've got approximately 6 or 7 questions to go through for this breakout session. And we've got about half an hour, which means we've roughly got about 5 or 6 minutes per question, really. Though I do imagine some of them will kind of merge into each other. And then what we need to do is also feed back some of our thoughts to the main group as well. So do we need a round of introductions, or people feel comfortable just kind of jumping straight into it? How do people feel? Because we haven't got much time. We'll jump straight into it because we've only got half an hour or so, because it usually takes like 10 minutes to get around everybody. I'm not particularly precious about people putting their hands up. So feel free to jump in whenever you have a question, but obviously if you can allow other people to speak, that'd be great. The very first question that was posed was, how can we as individuals help primary care networks, and how can we help them look to engage and develop in the future? Would anyone like to comment on that?
Yeah.
Yep, David, come on. What's your thoughts?
I think to start with, nobody would be anywhere if it wasn't for the people we refer to as patients. And I guess we say that in both senses of the word. If we're going to help, then I think we have to have a sense of that help is going to be listened to. I said before that how are we going to get these things to develop, given that some were virtual even before COVID. Some GP practices probably wish they were virtual where they're physical. We need to find a way, if we're going to assist in the development of primary care, a way of ensuring that the patient is.
Sorry.
Yeah, some background noise.
Yeah, sorry.
A way of ensuring that the patient voice is actually heard. So it's all very well to say, how can we individually help? But the question really is that those individuals who do help, how can we guarantee that their voice will be heard, and how are we going to do that?
Okay. Anybody else want to come in on that? Anne, did you have your hand up there?
I did. I would like to say something. I was trying to work out which of these it was better to pick up first. but bearing in mind a large swathe of patients across the region don't have access to digital equipment. They can't access it. I think that's one of the things that we need to tackle going through this list, because it's fine for us being able to jump on a Zoom call or whatever and Microsoft Teams call and just talk about it, but we're missing out on loads of people who can't do that, and we're not tackling the reasons why they can't do that. It could, there are many reasons why they can't do that.
Yeah.
We're all patients. We all have a voice. And we have to reach those who aren't as able to use that voice.
Just as a reminder, if people could try and remain on mute unless they're chatting, that'd be really helpful, because there's a bit of background noise coming through, which is making it a bit hard to hear. But no, some really good points there about the issues around digital inclusion, and that we're missing out on large swathes of patients who don't feel comfortable getting involved. Does anybody else want to comment on that in any way?
Do we have any sense of how many patients aren't able to access websites or whatever digitally? Do we know what the percentage is?
I don't think so. I don't think there'll be a definite percentage. It will depend quite significantly on, but there's lots of different issues, whether that be about someone's ability to afford to have the equipment, whether they've got the language skills. It's quite a broad range of issues.
Yeah, no, I'm aware of that. I just wondered if we had a sense of whether each practice has a sense of how many of their patients can or can't or are unable to access them digitally.
I don't know. I don't think that's a piece of work that practices have looked into, to be honest.
Actually, it has, Dan.
Has it? Okay.
Yeah. I've had cause this past week to look at the requirements of the Digital Data Protection Manager.
Right, okay.
And their role for a course I'm taking. And every practice has to have a person there who is responsible for all the patients being able to be contacted and involved. And it's when a patient joins a practice, they need to say how they can be contacted, what data can be used and shared. And this is held within the practices. So they have it. It's just a matter of whether or not they look at it in this way.
Yeah. Yes, every time a patient will join, they'll fill in that information. I guess it's whether or not they still have the ability to have a mobile phone to be able to use stuff online, I guess is the issue. You can have a mobile phone, have the IT, but not have the skill set to access that. But yes, that's a good point. Violet, you put a comment in the chat saying having a blended system whereby those can choose to discuss online or face-to-face or even on the telephone. Yeah, I completely agree. There needs to be a blended system going forward. I can't see how any of the system would work. Obviously, over the past 18 months or so, we've been kind of pigeonholed into this way of working purely because of the pandemic, and hopefully as things start opening up, more opportunities to do broader engagement will take place and have those broader conversations. Kate, you've got your hand up.
Yes, I was going to say, I think there has been research that shows that amongst older people, it's just under 50% are not digitally inclined. And then you've got the more deprived areas and deprived communities, and it's about 30% who are not online. Now, those are pieces of data I've read over the last year. So I actually think, what Violet says is absolutely right, because it's significant, the difference. And if you're deprived in one area, then that means your needs and your health needs might be greater anyway. Mm-hmm. So I think it's really, really important that we do not try and do everything digitally, and we make that really, really clear to the PCNs and whoever it is we engage with.
Yeah, I agree. I totally agree. Violet, you got your hand up. Are you wanting to come in there?
Yes. Sorry, I can't get my camera to turn on. I don't know why. But I think that as been said, that there needs to be a database of each GP needs to have one, and I think it shouldn't be when we get out of COVID and all the rest of it. This aspect of how we contact people and how people are contacting various opinions, ideas should be maintained. And even if it's by telephone, I think that would be, at a meeting like this, on Zoom, etc., and probably on here on Teams as well, you can have a contact by a telephone. Why not? And if that would get people who would normally not be involved, that would be great. And I think that's very vital going forward because otherwise people are going to be disenfranchised in many, many ways in relation to their health and many other aspects.
Yeah, no, I agree. Although the GPs may have the information, they do need to understand how a patient wants to be involved and engaged. I guess there's a difference between having a list of patients who are happy to receive emails and use stuff digitally to whether they want to engage digitally. There's two sides to that coin.
Yes.
I'm wary of time, so I guess we'll move on to the next question, which I'm assuming will probably kind of take up the belly of this conversation, which is what can patient participation groups offer to primary care networks to support engagement and involvement? And I guess one of my first questions off that would be, do you feel PPGs or patient participation groups are in a place currently to offer that support, or is it something that needs to be looked at? I've got a hand up at the bottom, and that is Terry.
I work with Jesmond Health Partnership, PPG, and with Health Watch around the PPG work that they've been doing. And for me, they are the natural contact in their patient community. And I appreciate communities are a different thing to define, but within the patient community. So they are the natural link point. And we would like to feel that PPGs are the safe link point, because you're not bothering the doctors, you don't have to worry about that. Yeah. But if you lose that direct connection between the PPG members who are patients and the practice patient base itself, then you've lost that familiarity and you've lost that safe space and closeness, which I think is vital to a good PPG and what it can achieve within the practice.
Yeah, that makes sense. Brooke, Violet, you had your hand up next, and then we'll come to Anne.
Apologies, I didn't take my hand down.
Apologies. Oh, no problem at all. Anne?
Just to add to what Terry said, we really don't want another layer of bureaucracy either within this. So, why have another section of people? You have people with experience of, Elizabeth and I go back many years on this particular piece of work. So you have people with experience and the knowledge and are involved in other areas of health and have other interests who contribute to this. So why look at another organisation or another level of people to operate? And right, as Terry said, we don't want to lose the connectivity that we already have.
Okay, great. Anybody else want to come in? No, do you feel, and obviously the patient participation groups vary quite broadly across Newcastle in terms of how active they are. Do you feel there's an exercise in actually pulling those PPGs together to understand how they can support? Because I guess what we don't want to happen is for one area to have a really strong PPG. For example, if you're within a certain PCN, you might have one very active patient participation group. Do you think that patient participation group could offer support to the other practices to help develop their patient participation groups? Terry, sorry. Terry, you came in first there.
I would agree that there is wide diversity across PPGs, their state of maturity, their activity, and so forth across Newcastle and Gateshead. And that again is something that's been shown by the work that Healthwatch has done. But I think that is inevitable because the demographic profile, the mix of people you get in different areas is different. So if you're working in a very deprived area, then you are likely to have different resources within your PPG than if you're working in a totally undeprived area, 10 to 1 or something like that. You've got different facilities within the practice itself. You've got a meeting room, you haven't got a meeting room. You've got different interests within the PPG members who are keen on this because it's a local issue. They don't care about it because it's not a local issue for them. And you've got to maintain that diversity. So although there is obviously scope to help across PPGs, a one-size-fits-all is never going to be appropriate because the practices aren't the same size and shape as each other. And it's setting out the stuff which could work and how to do it. And the PPG award from Healthwatch was a stab at looking at that. And it could do with a bit of revision now that we've got some of the preliminary data in, but that's still to be evaluated. But it is a support mechanism where that is needed. I agree that in a PCN, there is a possibility that one more mature PPG tries to take over the others and tell them what to do, and that would just alienate everybody from top to bottom. So it's got to be managed very sensitively. But supporting PPGs amongst themselves in a PCN, I think, would be an extremely strong way forward, and keeping that practice focus so that it is a home facility that you're using. It's not another layer of management somewhere.
Yeah, that's great. And I guess one of my questions would be, and I'll come to you in a second, Anne, as well, would be, as a PPG is often quite internally focused on that one practice. Do you feel, kind of some of your PPG members, do you feel confident that a PPG would be happy to kind of stick their head above the parapet to an extent and get involved in other wider pieces of work?
Yes. Yes, I do.
Perfect. Simple answer.
I think if you look back to the early days of PPGs, when it was Newcastle East and Newcastle West, etc., we had a group called the Acorn Group, and it was a representative from each PPG, and we met every sort of 6 weeks. And it was a really useful forum for learning about new things that were being introduced, but also for sharing. We'd come up with a problem, and it was you could share it with the rest of the group, and sometimes a different PPG had an answer or a possible way forward. And I think you could have that extra layer. And certainly Judy and I from the Grove and JHP are experimenting with that at the moment. And we will see how it goes, but we thought it might be useful to see what would be possible. Whether one could at that level, maybe, you meet with the pharmacist, you meet with the social prescriber, you then have information that you can pass on to figure out how to pass on to your other patients. There may be things that we could organize that would allow more patients to understand the changes that are going on and what is now available to them at GP level, at PCN level. So that seems to me there are a range of things that you could do, adding, so with just the existing PPGs, if they're there, being added on to in that way.
One of the things that in our first experimental meeting, we determined as a use possibly for the PPGs was that we could help our primary care network with their priorities. So when they were deciding which priority to attack first, would have most impact, we could be a sounding board for that because we represent the patients. And we have mechanisms for gathering information from the practice patients. So we've made a start.
Yeah, and that kind of jumps a question I saw. So keep that fresh in your mind there, Judy. Anne, you had your hand up. You put it down as no. David, you've got your hand up.
Yeah, I mean, just following on from the comment about the Acorn Group, in the former in Newcastle West, there was what was called the Patient Forum, which was their version of it, and we had the odd plenary session too between us as a whole of Newcastle group. that was also quite successful, and we had a number of sort of presentations which we drove in an agenda group. We drove the agenda forward about the things that we wanted to talk about. The meeting that we're sitting in right now, it was the replacement for the groups in the 3 different areas. There was a Gateshead, there was Newcastle East, Newcastle West, and the one we're sitting in right now is the replacement for it. And you know, on the basis that we were able to meet and discuss things that were of common interest, those how we describe them, those groups were quite successful. I'm not sure this one is quite as successful. We see an awful lot of presentations, but not a lot of discussion. And one wonders whether, you know, if we put our efforts into something which is more local to us, so the PCN, not quite the whole of Newcastle, not quite the whole of Gateshead, not quite the whole of you know, anywhere, but a subdivision nevertheless. If we put our efforts into that where it's actually closer to the patient, whether we would have a more beneficial effect.
Thanks, David. I'm obviously very wary of time, so I'm going to try and get through some of the questions. And obviously, Brenda, you're here representing, for example, the Stroke Association. And one of the questions is, as organisations, how do you feel you could support PCNs? How would you feel like, for example, the Stroke Association and other organisations could support the PCNs to be more effective?
Well, we gather a lot of information about clients, obviously stroke related, but we also pick up other health issues that are involved when we're dealing with stroke clients. We know when 6-month reviews are due for people, that kind of thing, you know, so we could help out with reminders about medication reviews, that kind of thing. Obviously we're stroke specific, but there's a lot of information that we gather that we could probably pass on that would be of help.
So providing that sort of a more comprehensive view. Yeah.
Yes, yeah. Mm-hmm. And obviously we could we could offer a service that we could take some of the pressure off by doing a particular service around stroke for them, you know, being there. We could have more involvement in the surgeries where people could be directed to us, a little bit like the social prescribing, but we could, you know, people could be directed towards us with their stroke related problems.
Mm-hmm. Sounds great. Simon, you got your hand up?
Yeah, at Search, where we are actually working with the PCNs, we started a delayed service in the Outer West in July. It was supposed to start last March, but we had to sort of remodel it. And in the Inner West, we're busy recruiting for one of the care home social prescribing care coordinators. One of the things that we discussed with the CCG before, well, over the last few years, was around how they could reach more people. So this will you know, transfer to the PCNs really. The people that Search usually work with, a lot of them people are isolated. They come to groups with Search, but they wouldn't get involved in other groups because they've sort of built that sort of confidence within that Search network. So what we said to the CCG, and this will transfer to PCNs, is that if they have people that they want to send out to our groups to engage people, to talk to people, or they have questionnaires that they want, you know, feedback on, we're willing to do that within the groups and the networks that we've got.
Mm-hmm. Great, brilliant. David, you had your hand up.
Yeah, I was just following on this thing about organisations. One of the things I do for my sins, I'm an awareness speaker for Prostate Cancer UK, and as you're probably aware, prostate cancer is you know, the most diagnosed cancer, unfortunately, now in the UK. I'm also a one-to-one counsellor, so I speak to men directly and individually and privately about, you know, their concerns around their treatment. but we have an awful lot of data and information that we can give to men who are reluctant, to say the least, to seek medical help, even when they might admit privately there's a problem. Somehow confronting it makes it real, and that is reflected in our discussions with them as individual patients. So there is something we can do, and I think that in general for organisations, that is something which the health service has been, you know, however you represent it, has been poor at taking up the help of third party organisations. Mm-hmm. And there's there's a well of expertise. You know, it doesn't matter which organisation, which you're talking about. Across the board, there will be somebody who represents that level of expertise which is being ignored.
Great. Yeah, I think that there's some really good points about helping to widen that reach into communities and providing those opportunities. I did see David Black. Did you have your hand up? Did you want to come in there?
Yeah, I was in the middle of typing a message.
Okay.
It's all right. I can read it out. So I think you need to identify those GPs who are failing to engage with patients and are not running PPGs at present. That is where I think you need to concentrate on, not the very successful PPGs that were, well, to be frank, I get sick of hearing about in some of the more wealthy areas of Newcastle. Just on the basis of speaking to a few patients, I know of 3 GP surgeries where I'd be starting to look. And what I do now, I just continue to complain and raise issues in a vain attempt to try to get some kind of change. But there's problems out there. It's great to hear the good work that is happening in Newcastle and Gateshead, but I would suggest there's GP surgeries who all of this means nothing to.
Yeah, that's a very good point, David. I think there is a very mixed bag of PPGs out there, some which are working, some which aren't. And yes, there probably needs to be a bit of a look at those PCNs and those individual practices that maybe aren't active within that, and how they can be supported, and maybe learn some lessons from the other active ones which are working well.
If the patients don't do this, then you'll just be forgot about. It'll be social exclusion. Those with a voice and who are confident will have a PPG, and other areas won't. But it's how you get individual patients together outside of the surgery.
Yeah. Good point, David. Anne, did you put your hand up?
Yes, I did, and I think that leads into what the last point, which I've forgotten exactly what it said, but it's basically about the do we need to develop a plan for engagement and involvement? Mm-hmm. The PCNs now, with their set GP practices within there, should be looking to see who within that group does have a PPG and does have an actual physical PPG as opposed to an online PPG. Mm-hmm. And perhaps within that group, yes, if one can help another one, that would be great. But if they talking about, for example, a PCN that has a particular area of need, area of people less able to participate in other areas, they need to be looking at that and finding out why and talking to their patients. And sometimes, you know, from my own PPG, I've said, can you not, when the patients are in the practice getting treatment with the nurse or, you know, the GP, can you not ask a couple of questions or refer them on or give them some advice? I know it's not always practical, particularly if they only have 10 minutes or so having a conversation, but they could say, well, go and see so outside of my consulting rooms, and then you'll get a little bit more information. So it can be done. But the PCNs now are in a prime position to make sure that everybody within that PCN area is working to the same level.
Yeah, that's a very good point, Anne. Thanks for raising that. I know we've touched on this point a little bit by mentioning the Acorn group and the West Newcastle group as well. And one of the questions is, would a PCN level PPG be effective? I know we've mentioned about the let's not keep recreating the wheel, but do you feel having a a practice participation group which covers all those practices, is that a positive step, or was that just adding more layers?
I think it could be a positive step. I mean, it obviously depends on the area, depends on the groups, but I think a key role that broader group could be is one practice may have one set of problems, but the other one may have a variant on it, and another might have something else. But if you bring them together, you may come up together with a possible way forward in terms of communication, in terms of looking at services, etc. That you might come up with something that worked for your practice, but actually it might work for several others as well. And I think sharing that makes sense.
Yeah, definitely. Excellent, thanks for that. Kate, you put your hand up.
I think what worries me a little bit is how much any of these structures are going to be driven by clinicians and how much by the patient. And I feel very strongly that those that are successful have at least a partnership approach with the clinical team in drawing up agendas and making sure that a good range of topics are discussed. I suppose that's the only thing I would say. I'm not too worried about what those structures are. I could tell you there isn't much of one where I am. There was a virtual group, but they started off as a physically meeting group, then it became a virtual group. And then, my mother-in-law had a stroke and she was on the group, and once she had the stroke, she was just dropped, which was completely wrong. And I thought to myself, it's only if you can fit in around the clinicians and the clinicians' time that you can get involved and have an impact. And that's why I say I think we need more patient control over whatever the structure is.
Yeah, great. There's our hands kind of lingering from previous comments, but I think Judy and David both had their hands up as well. So, Judy, do you want to come in?
I'm sorry, David, it's going to annoy you again, but after our successful first meeting, I had a long chat with the practice manager at my practice, and they are determined that regardless of whether we merge as a group or meet regularly as a group, which I think is a good interim step, they want to keep their own PPG to act as a sounding board for the practice partners when they're making changes or looking at priorities. So I think that there is room for both. And it seems to me that in an ideal world, we would have our local issues in our local meeting for 20 or 30 minutes and then meet as a larger PCN and discuss things of interest in all of our groups. I don't think they're mutually exclusive. I know, Anne, this isn't in line with your keeping things slim and trim.
That's a good point. That is, I guess, what they've got to juggle between creating more groups that the same people attend or working a way to streamline those. David, you had your hand up as well.
Yeah, echoing, I suppose, a bit what Judy's just said, but yeah, I think if we're going to have PCNs, then we need to have, the patients present. Otherwise, they're going to get sort of a bit sidelined as the PCNs start to sort of wag the dog to a certain extent. The other issue that's concerning me is, again, not reinventing, well, to a certain extent reinventing the wheel, is that we did very much have in the old forums have much more control over our agenda. And what it was as patients that we wanted to discuss. I'm very aware that in the new arrangements, the ones that we're sitting in now, it's very didactic, and we get served up with presentations from the CCG, but there is very little opportunity for us to drive an agenda forward. And if the PCNs were a way of driving a patient agenda forward, then I'd be all for it.
To come in on that point, David, I mean, you're right, we do get a lot of information coming from the CCGs, but there is a standing steering group which helps to sort of discuss those topics that we bring forward, and there was a couple of people on this call that are part of those groups, and there are activities that we have done, though it's been a little bit so because of the nature of us being in the lockdown and doing things digitally, where we do look at some of the issues that were highlighted, and as part of the evaluation forms, we're always asking for people to highlight the issues they would like to see brought forward. But I get your sentiment and the need for it to be kind of patient driven, or for at least to be at least a partnership where patients can address agenda items and bring them forward. So thinking about what we've just discussed there, and that the possibility of having both the practice PPG and then obviously the PCN PPG, and again, sorry for all the acronyms, it's just much easier than kind of spelling it out. How could that be effective? I know we've discussed very slightly on the different layers. I know Judy mentioned the whole part of having part of a meeting be dedicated to an individual practice, and then the second part maybe dedicated to a PPG. Do people feel that would be an effective way to kind of look at this? Or do people think they should be standalone large meetings that everyone goes to? I mean, what should it be that it's representation from one PPG goes to an ACORNet group? What do people feel? What should it look like? Anne, you got your hand up?
Yeah, going back to what Elizabeth said earlier on, you know, each GP practice PPG could nominate one person to represent them within the PCN group. So, for example, if you've got 6 practices, you've got 6 members, they will know what's already been discussed at their own PPG. They will know what their patients think, you know, and what the clinicians think, and they can look to see it at the higher level. But that's going to depend on our capacity.
Yeah.
So, you know, again, we're talking about another group. Do we have the capacity to attend another group? Perhaps if they were less regular. You know, these groups are once a month, and we've got the steering group in between, so it's quite time consuming. So you have to allow for people being able to do that.
Yeah. Judy, is that a hand up, or is that an old hand? No. Terry, is that a hand up, or is that an old hand?
That's an old hand, I'm afraid.
No problem. Elizabeth, is that an old hand? Or was that
yes, I think so. Yeah.
Well, that's fine. I mean, I guess, I mean, reflecting, as you say, the recreating the wheel of the old way of working. You had obviously the ACORN group, which you were part of, which I think was very much like how you kind of put out there a kind of representation from the practice. And then, as I recall, the group that David refers to, which was the West Newcastle CCG patient participation group, was a kind of a larger one meeting that everyone was invited to.
Yeah.
So there was 2 very different ways of working in the city itself. So which would be the preferred sort of method, or is it just about horses for courses within each of these PPG, within each of these PCNs, that they just canvass their PPGs and work out which is the best way for them?
My instinct is that it might work best within each PCN. So for some, the ACORN method might work best. For some, the sort of West End method, which we were involved with too, as David has said. I don't know that you can prescribe any one thing. I think it has to come naturally out of the grouping of GPs and in the PCN. That's my instinct. I don't know.
No, and that makes sense. And I think as Terry mentioned earlier on, it's about one size doesn't fit all, so it's about what works best for the PCN. So that's a great point. Terry, did you want to come in because your hand's gone up?
I haven't put my hand back up again.
Oh, sorry, must be
still up.
Caroline, I think you've popped your hand up.
Yeah, I think just picking up on what Elizabeth just said there, and having listened to the sort of previous bits of the conversation, I guess there's a bit around in terms of, I get each PCN might do it differently, but again, it's like, how much do you as patients want to be led, or how much do you want to lead? Because I think what I've been hearing in some of the other parts of the conversation is it's going to be much more patient focused than clinician kind of focused in terms of agendas and what's important to patients. So I'm going to kind of challenge the group back there in terms of saying, actually, so if we're going to have within each PCN the opportunity to maybe bring PPGs together, how as you as patients can you drive that? And how do you think that would be received by the clinicians? Because I know what I would be saying to them.
Anne, do you want to come in there?
Yeah, that's an interesting point. And, you know, something that we've tried to explore before with my own practice, because my own practice doesn't operate the way that, say, for example, Gosforth and Jesmond operate, where the patients actually run the patient practice group. Ours is controlled by the practice manager. And, you know, I think if you explore what's happening within each patient practice, you would get an overview of how different they all are. Well, you know, from not having a one to having a one that's being run by the patients and everything in between. So I think that's probably something that you should, not saying you should do, but could be done first to find out what the differences are right across the practices and the differences within the PCNs. And then we can perhaps all work towards providing a solution to that going forward.
Okay, interesting.
Yeah, good idea.
Yeah, thanks for that, Anne. I think we're getting pretty close to our finishing line. So kind of one of the very last questions that was put forward was, do we need to develop a plan to support wider engagement and involvement, which could maybe be trialled within 1 or 2 PCNs? So I guess it's kind of looking at what sort of plan would we want to see, and what plan can we support? So are there any thoughts on that, or do you feel that it's a matter of actually going off what's been said, and that there's a need to maybe get the PCNs to assess where they are before that plan even takes place? David, give it your hand up.
Yeah, I think Anne sort of put her finger on it. I think we need to understand what we've got across the patch before we can develop a plan. Can't develop a plan on nothing, so we need to understand what's going on first and then plan on the basis of that. That might suggest where, you know, a PCN might be more successful as an exemplar, and where, you know, the effort might be wasted in the short term.
That's a good point. It's a very good point. So we probably, one of the points you might be feeding back, actually what we need to do is ask PCNs to basically do a little bit of work and address where they are PPG wise, how those PPGs are active, how they work. And once we have an understanding of that, then we can maybe look at how we can support those PCNs to support, sorry, those PPGs to support those PCNs. Judy, hand up there.
Should we perhaps put together a questionnaire to go out to all of them and have a working group that looks at the material and collates it for distribution amongst us all? it'd be interesting to see, for example, just how many responses we get. That will tell us something.
Yep. So would your idea would be that as part of the, I guess it would be the steering group who would probably lead on that for the PCF, that we do a little bit of investigation to see what the landscape's like is out there, what landscape is like out there when it comes to the PCNs and the PPGs and how active they are, how they're managed, how they're run. And then that can be used as a foundation to look at supporting wider engagement and involvement going forward.
Well said.
Simon, you popped your hand up there.
Yeah, it was just to say that as part of Collaborative Newcastle, I'm involved in that, and one of the groups that I'm involved in, we're looking at how people feed into health and social care, and what engagement groups there are out there. And one of the things that we want to try and improve as part of this process is the feedback from, because often people are consulted and and fed in, and they don't get that feedback back. So one of the groups that we're looking at as part of Collaborative Newcastle is to sort of look at what systems are already out there for engagement and how that engagement works. So I think from what the conversation is saying today is that this is another sort of study of like, what have we got and what are we looking at. So it seems like this is being done in a number of different forums, looking at what engagement processes that there is in place. So maybe this, again, it's something about coming together and sharing all of that.
Yeah, and I guess it would make perfect sense for PCNs to have multiple avenues for engagement and to be aware of them all, whether that's through the patient groups and wider PCN patient groups, and through other engagement activities, if it's through organisations that are running events, exercises, or other networks. It makes perfect sense to have a really good view of what's taking place in that area. I know there's been lots of comments in the chat, and because I've been kind of doing the talking bit, I haven't been able to reflect them. I'll just start at the bottom. Terry, you've mentioned interested about Anne's point about looking at the different PPGs for a long time. I support your suggestion. Great. If we don't know what there is out there, we can support development or join. Yeah. So I think that's a very good point. I think that's probably what we'll probably be feeding back to the wider group, that actually maybe there's a little bit of an exercise that we need to do to really understand what the landscape's like out there before a plan is in place. Because a bit like you said, David, what if we can find some examples where it's working and we can highlight those? They can be used as templates or examples of good practice that we can take to other PCNs to really highlight the benefits of putting the effort in and the benefits of doing engagement. Great. Well, I know we're coming to the end of this discussion now. Is there any other points we want to raise when thinking about the PCNs, engagement, patient engagement, anything like that?
Brenda, sorry, I've just typed it in the bar. I was just going to say there's going to have to be information sharing agreements with outside organisations, with the PCNs, to allow us to work together, obviously in line with GDPR, but that's one of the big stumbling blocks that I think we always have as outside organisations with anything to do with the NHS. So that would be something that would have to be looked at, I think.
Yeah. That's a good point. There's always the bureaucracy that needs to be managed, all that red tape. I mean, I guess one of my points, going back to something you raised, Dan, about the ask of the individuals and the PPGs. As individuals that coming along these meetings, would you welcome the opportunity to be more involved in a PCN and going to more meetings, or do you feel there are better ways to kind of get involved and provide that feedback?
I would certainly welcome being contacted and being involved in, as we are now, being involved in discussing it. Like some other people, my time is quite limited. If I were only a patient, it would be great. but you know, I do have other responsibilities, which is why I particularly said about the you know, individual capacity as well. But I mean, I'm there as much as I can be.
Great. Well, I think we've come to the end, because as far as I was aware, we were going back in at 1:45, so it's now 1:45 now. So we should be getting moved back into the main room just automatically, as far as I'm aware. What I'll be feeding back, and I think our key point will be feeding back, will be that exercise to understand the current lay of the land, to understand what PPGs, how they're operating and what they look like within the PCNs. And that needs to be used as a foundation before any plan is developed. That'll be my key point. Is there anything else people would like me to feed back from the discussions that we've had today?
Dan, would that involve not only looking at the sort of GPs in the PCN, but would it also involve consulting any PPGs that are in that group as well, so that you've got both the patient and the practice view?
Yeah, I mean, yes, I mean, obviously it would be something that could be developed, and I guess if it's an action for the PPCEF, we can sit down and look at how we can develop that to make sure we get as wide a response as possible and make sure we're getting a broad range of feedback. I don't see why it wouldn't involve both, hopefully, as long as they've got active PPGs. But yeah, in the first instances, I imagine it would be just getting a lay of the land of GPs and the practice managers, and then finding out how best to contact the individuals on the list. But yeah, I don't see why it shouldn't involve all. And that's the best way to get that balanced view. I mean, you might find within some PCNs, the PPGs operate in completely alien ways. So you might have very active ones which are patient-led, some which are very clinician-led, some which are purely virtual. So it might be quite eye-opening to see how things are working. It also might highlight some real difficulties in trying to find a common way of working together as well, if they're coming from such different areas. But that it's better to know than not to know, and I think that's what we need before we can actually formulate any plans to start moving forward. But I think as Caroline sort of mentioned within the presentation, there's a great opportunity at the minute as PCNs start to look away from COVID and been solely focused on COVID and the vaccination programme, where there is a real opportunity to start to have an input and help to develop and design how they move forward and how we promote and encourage involvement and engagement. I do know before the COVID pandemic hit, there had been some events and some discussions around areas they were interested in looking at, and there had been some work taking place where they were running events. Unfortunately, that was paused and stopped. But as a PPCEF, as this group here, I don't think we were particularly involved in that. But this is our opportunity to basically kind of restart those conversations at a point where they're starting again. Judy, do you put your hand up there, or was that an old hand? I need to try and keep track of all the hands, keep popping up and popping down. Great. Well, I think Hannah's now on this call, so I'm assuming we'll be getting pulled in.
Yes, I'm just trying to do it at the moment. It's just whirring at the moment, but you are going to be reconnected up, all of you.
It's all right.
Okay.
That's all right. I was just wondering.
Dan, I think we've all rejoined, Dan.
Oh, there you go.
Oh, right. Okay.
I think we're all here.
I was expecting sort of the picture to change or something. Kind of catches you off guard a bit, doesn't it?
So thank you, everybody. I hope you found the breakout sessions useful. What we'll do is we'll have feedback from each of the two groups. Dan, who's feeding back from your group?
That'll be me.
Are you ready to do the feedback now?
Yeah, I'll keep it short and sweet. So yeah, we've had a really great discussion around PCNs and PPGs and discussed the ins and outs of it. I guess what we feel is what is probably the most important step to take forward would be understanding what the current landscape looks like within PCNs and PPGs. And what we would kind of propose is that the steering group for the PPCF actually look at engaging with the PCNs in a certain area across both areas to basically assess what PPGs look like, if they've got active PPGs, if they haven't got active PPGs, how they're led, and that would involve an engagement both the practice itself and hopefully chairs of those PPGs. And then once we have an understanding of the landscape and how things are working, we can look to develop a plan to make best use of that. Without understanding what things look like currently, the plan's on a very shaky foundation.
That's great, Dan. Lindsay, do you want feedback from the other group?
Yeah, so just following on from Dan there, yeah, we had a few members of our group who, you know, the PPG didn't exist or did in some form, but not accessible. So they definitely we recognised that and had a bit of a chat about that. We went back sort of before COVID and talked about the work that was done in Gateshead, which was by Healthwatch, and we just felt like there was so much good momentum getting picked up in terms of going forward with this that it could potentially be revisited. And I said I would dig that out for Jake to have a sort of look at and maybe link in with Healthwatch on that. We talked a little bit about how we could ask PPG members to act as advocates. So sometimes we felt like, I mean, this was mainly coming from myself, so not the group, but peers, so peers talking to peers sometimes works really well. So rather than us trying to get people to come to us, it could be that it's a really good mechanism to engage more with the PPGs, help support them to go out and engage with their peers and feed that back in. We had Joyce on the call from Berkeley Medical Group, and she gave an example actually where there had been a complaint come in about accessing the practice. So they have then gone out and said, well, to their PPG, could you actually ask your friends, other members who actually attend, about access to surgeries? And so it's just an example that it can happen, and it is happening. And then we also discussed a good idea around regular coffee mornings that used to happen before COVID. And guest speakers from Cancer UK would come in, Age UK, Mental Health UK, just getting guest speakers in, and then that kind of pulls in your audience, and they can get a benefit out for them, so they can get some information on services locally. And then we had another idea around linking up with the governors from the hospital, and I think just more of a collaborative approach and making sure that we're all talking to each other, because I think we're all trying to achieve the same thing. So it's just making sure that the links are there. And I used to attend an involvement meeting at the hospital, so I'm going to link Jake up with that, and then he'll be linking to the governors from there. And then we also discussed the potential to have some sort of portal where all the information is stored for staff and patients, and they can go on and see what's going on. And your Gates was mentioned, could this be the conduit for that? And then likewise, it would be information now for Newcastle, not to give Kate any more work, because I know you're already having a tough time in Newcastle with all the new stuff, transformation work. But it's just ideas that came out, and it was a really good discussion. I think I've covered most points.
That's great. Thanks, Lindsay. I'm just having a look at who's got their hands up. If you just bear with me a second. Elizabeth and Judy, you had your hands up, but I'm not sure whether there were hands up from when we joined the meeting.
They're old hands up.
Right, I can't see any of the hands up. Does anybody have any other questions that they'd like to raise or mention? No. I hope that you found the session useful. What we'll do is we're going to coordinate the feedback that we've been given at both groups. And what we'll do is we'll link in with Caroline and her team and share your views and your feedback. So if nobody's got any questions or answers, what we'll do is we'll move on to the last slide of the present, or one of the last slide is just to tell you about the date and time of the next meeting. The next meeting is going to be held on Monday, the 10th of May, between 10 and 12, and further information will follow. Finally, I'd like to say thank you to everyone. I obviously wasn't in both groups, but the group that we were in, it was really useful, and the feedback from Dan sounds as though, you know, it's been a really useful session. So thank you to everybody for attending. I'd just like to do a quick reminder. Could you please complete the link in the chat to SurveyMonkey, just to tell us a little bit about how the session went today, and this will help us improve our future online forums. And if you could complete it as soon as possible, we'd really be grateful. A written summary will be sent out to all, including those who were unable to attend, and the recording will be published on our website. So I would just like to thank everybody. I'm just going to have a quick look in the chat box to see. Yes, so Hannah's put the link in. I'm just seeing if there's any new questions. I know Violet mentioned connections with NIAS and the GPs would also be good, because the governor, yes, it is. It's about linking in with the governors of all our foundation trusts, including NIAS, the 2 acutes and the mental health trust. That's really good. Thank you. And Lindsay's put a comment in saying that you thought Brenda was in our session, and we thought, yeah, we thought we were talking to you, Brenda. So we wondered where you were. So so that's lovely. So if nobody has any questions, Judy, is that still an old hand? Yes. Yes. So I'll bring this session to a close. And again, thank you all for attending today, and I hope that you found the session useful. Thank you very much, everyone.
Thank you.
Bye.
Bye.
Bye.